Okay, thank you very much, Axel and David, and thanks to the organizers, and thanks for giving me the difficult task on new agents and new targets, which should come after the standard treatment. So I took a selection of some of the new data that may become relevant, and also some of the new concepts that may where we are working on, and where you may see in the future some new advances. Before doing that, just a couple of slides as an introduction to set the scene, because the new targets, new agents will build up on further what we have today. And indeed, 15, 20 years ago, we had only 5 FU. One drug, the median survival was extremely short. Very few patients lived 1 or 2 years when they had metastatic colorectal cancer. Today, we have more than 10 different agents approved, different cytotoxics, different targeted agents, as you can see there. And then there is a long list of new agents and new concepts and new targets that are coming through where we're working on. And with the gradual integration of these different agents in a kind of continuum of care, because that's what we do already right now with the existing agents, if we can integrate them and build up on what we know and in this setting, then we should be able to further increase the number of patients that are alive at 3, 4, 5 years and longer with metastatic colorectal cancer. But the art is going to be to individualize, to personalize the different for the different treatment options, and to come up with a complete, exact continuum of care, sequencing of the different treatment options that we do have. And therefore, the personalization and the individualization is important. And you know that we do more and more NGS testing in this setting. In Europe, we do a little bit less NGS testing in all patients, but we try to look at which markers are relevant and which are mandatory and should be done. And there we can say that some of the markers, and I will discuss that through my talk, especially then to focus on some of the new agents and new targets. Some of the markers are, of course, mandatory. RAS testing, BRAF testing, MSI testing, HER2 testing. These are 4 markers that we need to know in all patients, but the list is expanding, and I will come back to that in just a moment. And just to end up this introduction, that's a kind of, let's say, preferred choices guideline that we made also within the ESMO, the European Society of Medical Oncology guidelines, where we look in the beginning what is the goal. Is the goal cytoreduction, disease stabilization? Then we look at the molecular status, RAS and BRAF influence, what we do in first line. And then we look at the sidedness, as Axel introduced already, left-sided, right-sided. And then we may come up with a first-line treatment, and then later with later lines of treatment, but I'm sure Axel will expand more on that. If you look and focus then on the targets and on the individualization, and to put you in a few slides also some historical notes, and then to see where we're going. RAS testing has been integrated over the last 10 years. Initially it was KRAS testing, the light blue. Today we do complete RAS testing, also including KRAS exon 2, 3, 4, and RAS testing, that's the dark blue. And with that, 50% of patients are excluded for EGFR antibodies. That's clear. And that had an impact. If you see it here on the slide, on the top patients without a RAS mutation, so a RAS wild-type tumor, if we give them chemo plus or minus an EGFR antibody, we see an impact. We don't see an impact if patients have any RAS mutation from these antibodies. And that brings up to the left side of the slide that we start to exclude some patients as a first step in the integration of the treatments. Targets are important, and RAS, and let's expand also a few data and a few slides on this, because the RAS test and the presence of a RAS mutation is a dynamic event. We have now more and more data, and we have some data from some studies also using liquid biopsies and circulating DNA, that we see some changes under pressure, for instance, of the EGFR antibody. And that's illustrated here. And that brings the concept that in some patients, because of some pressure by the anti-EGFR antibody, that even patients that started as a RAS wild-type tumor, that we may have some clones coming through in the future, so that reintroduction of an anti-EGFR antibody may be of use in this. And that's illustrated also in the slide that I borrowed from José Tabernero here on the dynamics of the polyclonal evolution, where you can see on the left side the green, light green color, the wild-type clones. And then during the treatment with an EGFR antibody, you see that there are some, under pressure of the anti-EGFR antibody, some changes occurring that may lead and may explain the anti-EGFR antibody resistance. So that's not a new target, but that's an important data in this setting also in the management of colorectal cancer, that in the individualization that we have to look into and that we will feature in our treatment strategy also in the future. And that was the basis also for some studies on anti-EGFR antibody re-challenge, but especially also of, for instance, a new agent, SIMO04, which is a new anti-EGFR antibody, which was studied in patients failing the classic EGFR antibodies, cetuximab, and then later on, a reintroduction with this antibody, SIMO04, in all comers did not lead to any benefit. But if you look in the subgroup of patients who were then determined and followed with circulating DNA with liquid biopsies, and who had still a triplet circulating DNA negative tumor, and so no RAS mutation, no BRAF mutation, no EGFR mutation, if you then reintroduce this new antibody, then you can see in this subgroup of patients some benefit. So that's concepts how we develop new agents in this setting. So that it's a lot about also looking at and integrating new techniques such as the liquid biopsies, but we will talk more about that later during the meeting. On this pathway, on this MAP kinase signaling pathway, just downstream of RAS is BRAF. We know that around 8% of patients with colorectal cancer have a BRAF V600E mutation. We know that that's not always good news for the patients because these tumors are more aggressive. And we know that chemotherapy, classic chemotherapy, including also anti-EGFR antibodies, that they don't do very well in these patients with a BRAF V600E mutation. We have seen different studies looking at a BRAF inhibitor or a BRAF inhibitor with a MEK inhibitor, which were more active in patients with the same mutation if they had a melanoma. We have done some studies and some preclinical studies in this setting, in xenografts and later on in clinical studies in patients, that just a BRAF inhibitor or a MEK inhibitor or a BRAF plus MEK inhibitor does not have a dramatic effect. But then there were some preclinical data in xenografts and so on that combining and tackling the pathway, this MAP kinase pathway at different levels, EGFR, BRAF, and eventually in combination with in MEK, that could lead to a dramatic effect in some patients. And that's what is shown here on this slide from data from different phase 2 studies, looking at different combinations of EGFR, BRAF, and MEK inhibitors, for instance, that we saw some effects in some patients. And then there was a study from Scott Kopetz, which was relevant, which was a randomized phase 2 study, an important study, looking at patients with a BRAF V600 mutation. If you look at, in this setting, chemo, or then patients, another group of patients, a red curve, treated with cetuximab, irinotecan, and a BRAF inhibitor, vemurafenib, you can see that these patients did better than just with irinotecan cetuximab. That built up on the story. And then recently we are doing the Beacon study, of which we published 2 weeks ago, the lead-in safety phase, to which Axel referred already in the questions, with a combination of cetuximab, an EGFR antibody, plus a BRAF inhibitor, encorafenib, plus a MEK inhibitor, binimetinib. And there you can see that almost 50% of patients had an objective response, median survival over 15 months, progression-free survival of 8 months, And on top of the slide, you can see the waterfall plots of a SWOG study of cetuximab irinotecan in a similar group of patients, cross-trial comparisons with dramatic differences, leading to then the design of the phase 3 study, the phase 3 Beacon study, which can be hopefully pivotal for patients with a BRAF V600E mutation. So that's important in this setting, and that's one of the new targets, one of the new agents, where we do hope, if the study is positive, that we will have a new approved treatment. BRAF V600 is one subgroup, and then there is also the BRAF V non-600. The group of MD Anderson and Mayo Clinic have looked in a large number of patients to see what is the meaning, what is the significance of the non-V600 BRAF mutations. And indeed, they have shown that these patients with a BRAF V non-600 mutation, that they do much better than patients with a BRAF V600E mutation in this situation. And so in the knowledge, in the personalization, in the individualization, that's important. The treatments that we're speaking of, encorafenib, binimetinib, and cetuximab, for instance, as a regimen in the Beacon study, is for the V600E mutations, not for the more rare other group of non-V600 BRAF mutations. Checkpoint inhibition. Just a few words. There will be a lot of data coming through. We know that checkpoint inhibitors, they do work in metastatic colorectal cancer in those patients who have a microsatellite unstable tumor. That's 4 to 5% of the metastatic patients. That has been shown in different studies with pembrolizumab, nivolumab, and also with some other studies with a combination of nivolumab plus ipilimumab, CTLA-4 antibody. It's not clear what is the best. It seems in cross-trial comparisons that PD plus CTLA-4 inhibition is a bit more active. We have to work on that to see what is the best strategy. That's not yet clear. What is clear also is that those patients benefiting have sometimes a long-term benefit, as you can see here. That's not only in colorectal cancer, but also in other cancers. And just to illustrate that, to build them further on what is ongoing, an illustration, very short, of a patient with a chemorefractory tumor, retroperitoneal disease, peritoneal disease, skin metastasis, treated with a combination of nivo, ipilimumab for long term, now already for 3 years ongoing treatment. And you can see the dramatic response, initially pseudo-progression, meaning that this selection, individualization of treatment is important. It's not also easy. And what we really have to find and to work on is the patients with a microsatellite stable tumor. And there was some hope from a study from Joanna Bendel and colleagues that with a combination of MEK plus MEK inhibitor plus a PD antibody, that could lead to a benefit. Unfortunately, in the microsatellite stable tumors, the immune therapy concept, let's say PD antibody atezolizumab plus a MEK inhibitor, did not lead to any benefit compared to regorafenib. But it's clear that we have to go on with this, with immune therapy in this setting. And there are now a lot of concepts. I will not have the time to develop all these different concepts. Working at also, for instance, CAR T cells. And today we have started in Leuven, in my department, the first 5 patients with CAR T cells in metastatic colorectal cancer patients, either allogenic, either autologous CAR T cell injections in combination with chemotherapy. We have to work on anti-cancer vaccines. There's a lot of work ongoing on the microenvironment, so there's a lot of work ongoing beyond checkpoint inhibitors. And here you can see in one summary slide the different approaches, and again I will not expand in this short talk on the different approaches, just to illustrate that with the immune therapy, with the checkpoint inhibitors, that's only the very first beginning of what is ongoing in colorectal cancer, and that you can see some of the targets where there are different studies, some of them preclinical, some of them in early clinical work ongoing. And really the goal with this is to shape the curve. And I believe that that will be possible, to shape the survival curve. Today with chemotherapy, with targeted therapy, unfortunately we don't cure our patients. We increase the survival, we shift the curve to the right. But with immunotherapy and with different combination approaches, there is a belief and strong hope that we can lift the tail of the curve. And we see that in other cancers. We think that maybe in some cancers with new approaches of immunotherapy in combination with other strategies, that should be possible. Genomic markers as a target. There is a lot of work ongoing in this setting. And here you can see that, as I said in the beginning, there is a group of patients with a RAS mutation. The top, the green colors, 50%. There are the patients with a BRAF mutation, 8%. There are the patients with an MSI tumor, 4 to 5%. But then you see that we start to segment that more and more. And that's, of course, an important argument in the future to look at these complete NGS panels in the future, because there will be patients that will have benefits from when we find some of these alterations. And I will develop with you a couple of these examples where we start to see some examples of a benefit in this situation. I will take you through HER2, NTRK. We have some data also that around 1% of patients with metastatic colorectal cancer have a pol E or pol D mutation, and that they are extremely sensitive to also checkpoint inhibitors. So there is a lot of ongoing in these small subgroups. That puts all of us in the difficult problems, because these trials are extremely difficult. The convincing, especially also the European authorities for approval, is going to be difficult without randomized data sets. But looking here in this setting, just a couple of examples. You see, and I will expand on that we know that 2% of patients with colorectal cancer have an HER2 amplification and 1% of patients have an HER2 mutation. We know that around 1% of colorectal cancer, or at max 1%, have an NTRK alteration. And you see on the right side the waterfall plots from patients with an HER2 amplification or an NTRK fusion, where with a direct targeted agent in this, that led to an important number of patients with a response. The example of HER2 amplification. As I mentioned, 2% of patients with metastatic disease have an HER2 amplification. We can enrich that by looking at left-sided RAS and BRAF wild-type patients that are then resistant to anti-EGFR antibody. If you don't want to do that in all patients, then it's 5% in this setting. We know that HER2 amplification has a predictive value, and we know from the Italian study, the Heracles study, that if we treat patients with an HER2 amplified tumor with a combination of trastuzumab plus lapatinib, that we see in around 1 out of 3 of the patients an objective response, as is shown here on this slide. Also, US study, My Pathway trial, with a combination of trastuzumab, pertuzumab, led to an objective response in almost 40% of the patients. It's all phase 2 data sets. It's extremely difficult to do large studies in this small subgroup of colorectal cancer patients. But the results for those patients who have this HER2 amplification may be dramatic in this situation. There are even now some data in HER2 amplified patients pre-treated with HER2 targeted treatment that then are exposed later on to DDM1, another anti-HER2 targeted agents, where you can see, according to the Italian experience, also some benefit in this group of patients. And there are different trials ongoing with TDM1, with a combination of pertuzumab TDM1, with other TKIs, HER2-targeted TKIs, tucatinib plus trastuzumab in this setting, as you can see. And there is some hope, at least in this subgroup of patients, that there may be some benefit, as well as in the HER2 mutants. As I said already, 1% of patients have a HER2 mutation. And also in this group of patients, we have limited data, but there are some data that this HER2 targeted strategy may lead to some benefit in these patients. Other genomic markers are even more rare than HER2. ATM, limited data, more in the preclinical data, telling us that PARP inhibition in combination with chemotherapy may be of benefit. MET amplification, also some preclinical data and early clinical data that a specific targeted therapy may be of benefit for these patients in this further unraveling of the taxonomy. I mentioned already the example of NTRK fusions. Recently, the FDA approved larotinib for patients with an NTRK fusion in this setting. Less than 1% of patients have that. But for those patients who have it, as we have seen in the New England publication, it may have a dramatic effect. And looking also at some other examples of sometimes case reports, ALK fusions, ROS fusions, RET fusions, we have drugs from other diseases, from other cancers that are active in this setting. So it is to be looked at in colorectal cancer, and some work is ongoing in this setting. And then we are doing some innovative projects, and I'm ending here almost, some innovative projects, such as, for instance, this EU framework project that we are doing, an academic study, looking at, for instance, what we call MSI-like patients, with an MSI-like signature, with a BRAF signature, with a TGF-beta signature, where we know that there are some agents from preclinical and from the analysis of the consensus molecular subtype work that was done as a global project, US and Europe, and in our center we also had a pivotal role in that project, as well as different American centers and Barcelona in this project. This unraveling of the colorectal cancer in the taxonomy in the 4 different groups, CMS colorectal cancer subtypes, CMS 1, 2, 3, 4. This knowledge will have in the future profound implications for our knowledge, as well as a further unraveling of, let's say, the easy anatomic localization, left-sided versus right-sided, where we have more and more information on what is the explanation. We don't have a complete gene signature of left-sided versus right-sided tumors, but we know that there are embryological functional differences, microbiome differences, genetic mutation differences, and epigenetic differences that may help us further to unravel specific targets in this setting for the patients with metastatic colorectal cancer. And finally, also, what is upcoming is also some data of the microbiome. We know that the microbiome may influence also the sensitivity to PD antibodies, to checkpoint inhibitors. We know that there are different microbiomes associated with these different molecular subtypes, as you've seen. And if this knowledge on, let's say, on preclinical and basic fundamental research is further ongoing, I'm convinced that we will have further new targets coming out of this CMS subtyping. And there are drugs also where we have a rationale that we can use them in the future for that. Thank you for your attention.